Thanks very much. Next, it's my pleasure to present our keynote speaker, Dr. Priscilla Callahan Lyon. She is trained as an internist and a pulmonologist and was in practice for many years before joining the FDA over 10 years ago. She has worked extensively on nicotine replacement therapy and has been engaged in a number of agency-wide initiatives on the Nicotine Steering Committee, the Tobacco Control Steering Committee, and the Tobacco Cessation Work Group. She continues to provide scientific input and expertise on policy matters. She's going to be speaking us today on treating smoking in vascular patients, an essential component of care. Green button to advance.
Gotcha. It is very simple. Good morning, and I'm very glad to be here, and very, very glad to support this wonderful initiative that you are starting. This is extremely important and very dear to my heart. I've been fighting for this for my entire professional career. So I'm going to talk a little bit about some of the public health burden of tobacco, which you're very aware of, overview of the Center for Tobacco Products and what we do and also what we can't do, some of our key initiatives and some resources that may be of some benefit to you in your clinics and in your patient care. So this is a graph of cigarette consumption between 1900 and 2020, and it's actually pretty interesting graph because what you'll see is it went up, and then when the first Surgeon General report came out in the mid-60s, we started to see a downslope, and over time, as we've had some other policy changes, such as some of the non-smokers' rights and additional Surgeon General's reports and the clean air policies, et cetera. It's continued to go down. However, it's still there, and smoking is still a problem. And if we look at this data from the CDC from 2020 and 2021, what we see is that in the adult population, and adults in this population are those over the age of 18, still have a smoking rate of around 11%, and that they also use other tobacco products, including e-cigarettes, cigars, smokeless tobacco, and pipes. And what's not shown on this graph is how many of them tend to use more than one type of tobacco product. And I think that's something important to keep in mind when we are talking with patients, is that you can't just go by what they say that they smoke per day. It's how much tobacco they use per day. So for those that may not be as familiar with Center for Tobacco Products, we have a very specific vision and mission. We want to make tobacco-related disease and death part of America's past, not part of our future. And we want to work for everyone in America to have a safer and healthier life due to less tobacco use. And we do this by trying to protect people from tobacco-related disease. However, it's also important to know what we can't do. When Congress wrote the Tobacco Control Act, they gave us regulatory authority over a lot of things. However, we are not allowed to set tax rates for tobacco products, for example. We don't regulate therapeutic products. That's in a different part of FDA. That's in the Center for Drugs. We don't set clean indoor air policies. That's not something that the Center for Tobacco is allowed to do. We can't regulate the growth of the tobacco. We cannot reduce or require the reduction of nicotine in tobacco products to zero. We can set a very low level, but we can't make it zero. That's specifically outlined in the Tobacco Control Act. CTP in and of itself does not provide cessation services, though we do support them heavily. We cannot ban all cigarettes, smokeless tobacco products, little cigars, other cigars, pipe tobacco, roll your own tobacco. We can't go in and ban them all. We would love to, but we are not allowed to do that. And we are not allowed to change the minimum age of sale for tobacco products, but fortunately that was taken care of thanks to President Trump in an act a couple years ago. So when the Congress wrote the Tobacco Control Act in 2009, they gave us the authority to regulate the manufacturing, distribution, and marketing of certain tobacco products. And then in 2016, we actually deemed authority over all tobacco products, including e-cigarettes. And it gave us the authority to extend it to products with nicotine that are made or derived from tobacco. And at the time, that seemed like that would be good enough. However, as you may well know, the tobacco companies decided to go with non-tobacco source nicotine and synthetic nicotine. And so as that became more and more of a problem, particularly in e-cigarette products, but also in some other products, the pouches and other products, the law was changed in 2022, went into effect April of last year, that gives us the authority over all nicotine-containing products that are, whether they're made or derived from tobacco or not, as long as it's not something that's considered to be a therapeutic or a food product. So FDA has been actively involved in 4 main activities. We review the tobacco product applications to ensure that any new products that are come on the market meet our public health standard. We ensure that the tobacco manufacturers and retailers follow the law, and specifically using surveillance and inspection and enforcement. We work to educate the public, and particularly youth. Our youth campaigns have been quite active over the years about the dangers of using tobacco product, and we also implement rules and guidances. Once these guidances and rules are in full effect, they do have the full effect of the law, once the rule is made and final. So FDA has or CTP has a public health standard. So we're different from other parts of FDA. We do not approve a tobacco product. Any product that we give authorization to is authorized for marketing, and we can authorize them for marketing if they meet the legal standard that's in place for that particular product. But we do not approve any of them. So as opposed to the Center for Drugs and Therapeutic Devices, we look at the marketing of the product. We ensure that marketing of the product is appropriate for the protection of public health. That's the standard that we use. And it requires that the applicant provides certain information to us, such as marketing restrictions and other information. We look at what the intended user population and what the risk is to that population. We also specifically evaluate the risk to youth, because that's a population of significant concern. We don't want these kids to start using tobacco products and then become addicted. We look at the labeling. We want to make sure that there's nothing on the label that implies that this product is less risky, because no tobacco product is safe and the products are never approved. This is different from the Center for Drugs and from the Center for Devices. These products have to be evaluated by FDA to be shown to be safe and effective for a particular population and for a specific condition. And so what this usually requires is non-clinical data as well as clinical testing, usually at least 2 clinical studies. And while all drugs have risk, they have to consider the drug's benefit as well as how the risk can be managed. The package labeling is carefully examined to make sure that it's accurate. And also the prescribers that are prescribing these prescription medications have some control over the rate of dispensing of the medications. That's not true in over-the-counter products. Over-the-counter products, obviously, patients can take on their own. However, there are very strict requirements that have to be met before a product can be sold over-the-counter. So CTP, as I said, is different. Our public health standard is a different weighing versus safety and efficacy, because we'll never achieve it on the safety side. So we're the only product regulated by FDA that routinely causes the death and disease of the patients that use our product. And because of this, we have a completely different regulatory standard. We have to take into account the effects on users and non-users. We have to take into account the potential benefit to users and the risk to those that are non-users, former users. And we have to evaluate all of this from a scientific standpoint to evaluate the potential for any ability to reduce the disease and death. We focus strongly on the public health aspect of it, particularly protecting youth. So we have reviewed, as you've probably seen in the news, a fair number of applications in the last couple years. When the PMTA rule, the pre-market tobacco product application rule, and the deadline was set, which was a court-imposed deadline, we got over 26 million applications. And needless to say, that was a bit overwhelming. But the good news is that we've taken action on over 99% of these. A lot of these were e-cigarette products. and we refused to accept or refused to file the letters and issued marketing denial orders for millions of these products. There are still a lot that are still under review, and those make the news on a regular basis. But we have made quite a bit of progress in reviewing these literally millions of applications. So what do we do when we're looking at flavored e-cigarettes? This was a question that was specifically asked as part of this presentation. So how do we evaluate a flavored e-cigarette? We have to consider that flavored e-cigarettes pose a unique risk, particularly to youth. We know this. This is very well established, well documented in the literature. So what we have done is try to make sure that the applications provide robust and reliable evidence that the use of this flavored product by an adult smoker will result in significant and substantial reduction in their cigarette use, but not increase their risk to youth. How do we do that? One of the big things is the difference between a flavored product and a tobacco flavored product. So a non-tobacco versus a tobacco flavored product. And what we have been asking companies to do is to show us that their flavored product, including menthol flavored product, actually will provide some additional benefit to the adult smoker over and above that of a tobacco flavored product of similar nature. Usually the same product in a tobacco flavor. So the burden is on the applicant to provide sufficient evidence to show that this product meets our criteria as being appropriate for the protection of public health, and that's that marketing of the product is appropriate for the protection of public health. To date, we have not authorized any menthol or flavored e-cigarette products as being appropriate for the protection of public health, but that's not to say that we couldn't. We've just not seen an application that provided the information that meets these criteria. So I'm going to switch a little bit now to our rulemaking process. And this is, if you don't know anything about the rulemaking process, I'm hoping I can give you a little bit of information. So after we write a proposed rule, it goes through a lot of internal review. So before we write the proposed rule, we have to have the scientific basis for the rule. So there's a lot of science in the rule. If you ever look at one of our proposed rules, and I was in practice for a long time, I know that nobody really does that. but if you were to get the urge to look at a proposed rule and looked at the preamble of the proposed rule, you would see that there are literally hundreds of scientific references supporting the basis for the rule. So we write the proposed rule. It goes through clearance at multiple levels, all the way up, usually depending on the rule, maybe even as far as the White House. Oops. So then we have a public comment period. So after we've proposed the rule, there's a public comment period. It's usually 60 to 90 days. And during that time, literally anyone can issue a comment. You can submit the comment to the docket. There's a website that tells you exactly how to do it. But the comment period is something to keep in mind if you were, or if the organization is going to submit a comment. They're not votes. This is not a popularity contest. Okay. Submitting 1,000 form letters is not nearly as effective as submitting one very well scientifically based comment that provides a clear vote or opinion on whether or not you think that it's a good rule, and your reasoning for why you think that it's a good rule or don't think it's a good rule, and any additional scientific information that you have that supports your opinion. Once we get all of the comments, and so for the proposed rules that we recently issued, we received hundreds of thousands of comments. Once we receive all these comments, then we go through and we actually will combine these into similar categories, and the final rule, when it is put forward, actually addresses every single comment in categories. So it takes quite a bit of time for us to go through, and if we make a change in the proposed rule, then we have to explain in our response to the comment what we were looking at and why we made the change. So what rules are we looking at right now? We have a nicotine product standard rule that has been listed in the unified agenda. We have stated, and the administration has agreed, that we intend to propose a product standard that would establish the maximum nicotine level in cigarettes and certain other combusted tobacco products. So this is a proposed rule that will hopefully come out in the next few months, and that will lower the amount of nicotine in cigarettes. Why would we do that? If they don't have as much nicotine, then and they're not as addictive, and then hopefully people will smoke fewer and gradually quit because they're not getting the nicotine that they were initially smoking the cigarette to obtain. Other rules. We have 2 proposed product standards, and product standards are one of our most powerful tools, issuing these product standards. So we have 2 that have been proposed. These were proposed last year. One of them prohibits menthol as a characterizing flavor in cigarettes. As you're aware, all other flavored cigarettes have already been prohibited, but this would prohibit menthol flavored cigarettes. And then the other proposed rule would prohibit all characterizing flavors in cigars, including menthol. Flavored cigars actually increased in popularity quite significantly when flavored cigarettes became unavailable, particularly flavored little cigars, which are more popular than we would like with young people, and have become quite a significant problem because not only are they flavored and more attractive, they also can be sold in smaller packages. Cigarettes by law can't be sold in anything less than a package of 20. Flavored cigars can be sold in smaller packages and therefore are less expensive and less cumbersome for the youth to acquire. So these are 2 proposed product standards that we have. If these go into effect, these could make a significant difference in tobacco use in young people as well as in certain populations of adult smokers as well. Now, like I said, when we proposed these rules, the comment period closed in August of last year, and we got over 250,000 comments to these 2 rules. So we are still looking at the comments to these 2 rules, but we are working to finalize these rules and have stated that we intend to publish these final rules sometime during this calendar year. Cessation interventions. Some of this is very obvious. Obviously, if you don't use tobacco products, you should never start. We try to avoid having youth use any tobacco products. There are many cessation products that are available for adults, including the nicotine replacement products as well as other prescription products. We also know that counseling does work, and the combination of counseling and medication works better than either one of them alone. Combination medical therapies also work, such as varenicline or bupropion with an NRT, and that combined with counseling is also very effective. And counseling can be delivered in any number of ways. It doesn't have to necessarily be in person. There have been some studies that have shown that text message programs, particularly for youth, can be particularly effective. And these other digital programs, apps, and various other things that people can use also can be quite helpful. And there is a brainwave deep cranial transcranial magnetic stimulation, a deep TMS device that does have a indication for short-term smoking cessation in adults that's available. For adult smokers that are unable to quit, however, unable to quit using the proven methods, it is possible that lower risk alternatives could be considered as they try to reduce their cigarette use. So CTP does believe that there is, while there's no safe tobacco products, there are tobacco products that are less risky than cigarettes. Cigarettes are the most commonly used products by adults, but we know that there are other products out there that are less risky, and as I've told people before, being less risky than a cigarette is a fairly low bar to meet. So it's not too hard to achieve that, but the hope is that we can gradually reduce risk and move people down this continuum of risk. It's very challenging to communicate on this. We have to be very careful that we communicate the right message to the adults as well as to the youth. We don't want to mistakenly deliver the wrong message to the wrong population. So this is something that we're actually researching within the agency and trying to determine the best methods for communicating this message. You've probably heard some talk recently about a cessation care package. This was described in a JAMA editorial that was written by Dr. Califf, the FDA commissioner, and Dr. Brian King, our CTP commissioner, or our director. And what they were talking about was a 3-level cessation care package focusing on health systems, individual therapy, and population therapy. So in terms of the population approach, we've got the cigarette, or the menthol cigarette standard, the cigar standard, and the nicotine standard. All of those are geared towards population effect. In terms of health systems, trying to come up with ways of making access to treatments barrier-free. There's clinical practice guidelines that are out there that I know you're all very familiar with. Clinician education and resources is certainly a way to approach health systems, and then the individual therapies. But how is this all really going to work? And what I wanted to focus a bit on was some of the health system interventions. And this was talked a little bit about in some of your previous talks, and the young man that just spoke, I think, talked about this to some degree. And it also, I think, incorporates very nicely with some of the information that was being described in the previous presentation of things that you collect, the information you collect from the patients as they're coming into the clinic and being seen. So tobacco use screening and making sure that there's appropriate inpatient cessation services and outpatient cessation services, providing the resources, including clinical guidelines, and proven cessation treatments, making these available to people. And also healthcare staff that are dedicated to providing cessation treatment, I think, is a very important part of this program. Every member of the team can have a role in cessation. Most people try several times before they manage to successfully quit, and making sure that every person on the team knows that they might be the one. Their story might be the one that persuades a patient to quit smoking. So don't think that you're unimportant. The med student, the nurse, the medical assistant, anybody, they can all participate in this. And I wanted to touch just a teensy bit on the 5 A's. I know everyone in this room is familiar with this, but one thing that I've noticed is that we tend to ask the question, do you smoke? That may or may not get you the information that you're actually looking for. We need to be specific. You need to ask, do you smoke? Do you use cigars? Do you use e-cigarettes? Do you use a combination of these? Unfortunately, our medical record systems are not very good at soliciting this information, so sometimes you have to actually put it in manually. But knowing what they use and how much they use is very important if you're going to go on to the next step, which is advising them and assessing their willingness to quit, helping them quit, and arranging for appropriate follow-up. If you've got a smoker that has already tried e-cigarettes and that they want to actually move more towards e-cigarettes, like I said, that's better than cigarettes. Move them down the continuum and then work on getting them to stop the e-cigarettes. It is all part of the continuum of risk. We recognize that it's very important to ensure broad and equitable access. We're working on this. There was a forum that was actually held at the White House last week. You may have heard something about this. It is focusing on this whole framework across HHS and across multiple non-government organizations as well to try to develop a better framework for providing smoking cessation therapies for anyone in the country that smokes. We have the nicotine replacement therapy product guideline that just came out, which does actually add a little bit more information about the nicotine replacement products and how they can be used and some of the indications that they could seek. And I want to quickly go through some of the resources that are available. Smokefree.gov, everytrycounts.gov, and the FDA Resources Library. Our resources library has posters and other information that are free. You can just go to the library and download these in a PDF format, print them out. They're available in English or in Spanish, and anyone that wants them can get them. We also have a safety reporting portal, and I would be remiss if I did not encourage you to submit any adverse event information that you have to the safety reporting portal. And I'll summarize by just saying we know that tobacco use remains the leading cause of preventable death and disease in the United States. We are continuing to work on this, and we are very, very glad to have you help us with this project. And I'll stop there.